So, thank you so much for giving the opportunity for this talk. So, today's talk is preventive strategy for cognitive health in aging. Next slide. First, if we talk about the global burden of the cognitive impairment or dementia worldwide, we can see that 57 million people had dementia worldwide and nearly 10 million new cases will add each year. So expected number of people will be tripled by 2050. And in these numbers, 60% will be from low to middle income countries. If we talk about health impact, the dementia is the seventh leading cause of death globally among older people, and it is the major contributor to disability and dependency among older adults. If we talk about economic burden, the global cost is 1.3 trillion US dollar, and the 50% of cost due to informal caregiving, and the average 5 hour of care giving 5 hours of care daily by the family members and caregivers provided. Next slide, please. So, why there is the need of preventive strategy for cognitive impairment, delay, and decline? So, the late life cognitive impairment, Alzheimer disease, and dementia are heterogeneous, multifactorial condition, and combination of genetic, vascular, metabolic, and lifestyle related factors. And the second is the dementia is a progressive continuum. It is not a overnight phenomena. It progresses from normal cognition to subjective cognitive impairment, mild cognitive impairment, and then mild, moderate, and severe dementia. So we have pre-dementia stages where preventive strategy can be applied and the progression to dementia can be delayed. And still there is no disease modifying therapy available for dementia. So there is immediate effort for non-pharmaceutical intervention needed to prevent this cognitive impairment and dementia. Next slide. If we talk about the risk factor of dementia, so the recently published Lancet Commission 2024 highlight the 14 modifiable risk factors. These were divided into the three parts: early life, midlife, and late life. In early life, less education was included, while the midlife contribute the 10 modifiable risk factors, including hearing loss, high LDL cholesterol, depression, traumatic brain injury, physical inactivity, diabetes, smoking, obesity, and excessive alcohol and hypertension. While in late life, social isolation, air pollution, and vision loss included. All these contributed to 45% of dementia cases. If we modify or prevent these risk factors, so 45% cases can be delayed or prevented. In these 14 modifiable risk factors, two risk factors were added in the recent 2024 commission. These are the high LDL cholesterol in midlife and vision impairment in the late life. Next slide, please. Now we now we talk about the preventive strategy that are beneficial and that are shown to be effective to delay the cognitive impairment in older age. Uh, Next slide, please. So the first preventive strategy comes the regular physical exercise. So how the regular physical exercise delay the cognitive impairment? So the mechanism include the improvement in the cardiovascular factor. These exercises lead to the diabetes, hypertension, hyperlipidemia, and obesity under control, and lead to the overall benefit in the cognitive impairment. Along these, there is the increased neurotrophic factor expression like brain-derived neurotrophic factor, IGF-1, and vascular endothelial growth factor. Also include the increased amyloid beta turnover, cerebral blood flow, and decreased inflammatory response. Even aerobic training lead to the larger hippocampal volume that is the key area of memory and solving the slow gray matter atrophy that is linked to the aging. Next slide, please. Now next come on the exercise ki which type exercises are important to show the delay. So in the studies, the exercises shown to be effective are aerobic exercise, resistance exercise, mind body exercise, multimodal, and low intensity exercises. In the recently published network meta-analysis in 2025, the mind-body exercise was found to be the most effective to delay the progression, especially in the subjective cognitive impairment older people. And the secondly effective was seen the multimodal and combined exercise. While if we see the all over the study, the aerobic exercise was shown to be the most effective, and these include the global cognition, executive function, and memory domain of the cognition. So these are the type of exercise that are shown to be effective to delay the cognitive impairment. Next question come on the exercise ki how much exercise duration is effective to see the effect on the cognitive impairment. So the combination of aerobic and resistance exercise, including the session, approximately 45 minutes, and it should be 3 times weekly, and it should be sustained over 3 to 6 months. These exercise durations shown to be best cognitive outcome for older adult at risk of cognitive decline or dementia. So it is also important duration of exercise to shown the delay rather than only the infrequently and exercises. Next slide. If we talk about the systemic review that included the 98 RCTs, includes 11,000 older adults. It shows the effect of physical exercise to influence the cognitive performance. In this, the type of exercises were included aerobic, resistance, mind-body activities like Tai Chi. The mechanism uh, include the improved brain metabolism, blood flow, and neuroplasticity and mood. So the main point of this systemic review was the exercises for at least 52 hours in session was shown to most effective to in cognitive decline. Next slide. The second preventive strategy come on the dietary pattern. So there are the two main dietary pattern were seen to delay the cognitive decline includes the Mediterranean diet and mind diet. Mind diet is the Mediterranean base intervention for neurodegenerative delay. These both diet are rich in vegetable, fruits, whole grain, olive oil, beans, nuts, and fish, while the mind diet mainly emphasizes on the green leafy vegetable and berries for enhance the brain protection. These diet improve the cognitive decline by providing anti-inflammatory, antioxidant, and neuroprotective nutrient. These support the brain structure and function by omega-3 fatty acids, polyphenol, and brain-derived neurotrophic factor enhancement. Next slide. Next come on the duration of the diet. How much duration is needed to show the effect? So adherence to the mind diet over a period of 4 to 5 years is associated with the slower cognitive decline and lower risk of dementia. While the shorter trial of mind diet shown to the effect on the mood but not on the cognitive changes. Next slide. If we see this meta-analysis role of Mediterranean diet in reducing the risk of cognitive impairment, dementia, and Alzheimer's disease, there were 23 studies included, and adherence to Mediterranean diet was associated with 11 to 30% reduction in the risk of age-related cognitive disorder, including cognitive impairment, dementia, and Alzheimer's disease. And the combined hazard ratio for cognitive impairment among those adhering to diet was 0.82 for dementia, 0.89 for Alzheimer's disease, and 0.70 for substantial protective effects. Next slide. The third preventive strategy comes cognitive stimulation. So cognitive stimulation intervention are effective in delaying or reducing cognitive decline among older adults, especially who are the mild cognitive impairment or subjective cognitive impairment. This cognitive stimulation enhance the cognitive reserve and compensate for age-related synaptic loss. These promote neuroplasticity and strengthen associated learning pathways. These reduce depressive symptoms, social isolation, both of which independently accelerate the decline. Next slide. If we talk about the effective dose of cognitive stimulation, so the minimum effective dose was 7 to 10 weeks, 2 sessions per week, 45 to 60 minutes. But to gain the maximum benefit from cognitive stimulation, there is needed of optimal duration is 12 to 24 weeks, 2 to 3 sessions per week, 45 to 60 minutes. So, by this, we can see that moderate intensity sustained program neither too brief nor too prolonged maximize the engagement, adherence, and neurocognitive benefit in older adults without creating the intervention fatigue. And the type of intervention included group cognitive stimulation therapy, individual cognitive stimulation therapy, and cognitive activity in the daily life. And the maximum domain affected were executive functions and memory functions. Next slide. The fourth preventive strategy come on the cardiometabolic. Comprehensive cardiometabolic risk reduction also necessary to see for the cognitive decline. It includes the optimized blood pressure, optimized blood glucose, and lipid. These substantially prevent or delay cognitive decline and dementia in older adults. Next slide. The fourth, untreated visual loss. This risk factor recently added by the Lancet Commission 2024. Vision impairment or loss in older adult is robust risk factor for cognitive decline due to combination of reduced sensory input for cognitive stimulation, increased social isolation, and mood disturbances. And the global prevalence of avoidable vision loss and blindness in adult is 55 year or older estimated to be 12.6%, and the higher prevalence was seen in the low income countries. A meta-analysis shows that vision loss was associated with the dementia with relative risk of 1.47. Next slide. So the intervention that target the vision health, like including the cataract surgery, vision aids, these they potentially delay the cognitive decline and important component for the dementia prevention. And the most important also that treatment of vision loss is effective and cost effective also for estimated 90% of people with vision impairment. Next slide. The risk factor comes in the older people is the air pollution. The airborne particulate can penetrate the blood-brain barrier through systemic circulation, inducing oxidative stress and neuroinflammation. They trigger the microglial activation, leading to neuronal injury and amyloid beta accumulation also. They reduce cerebral perfusion, accelerate white matter lesion. These are the hallmark of vascular and Alzheimer pathology. So the air pollution often high and increasing particulate matter 2.5 and 10 concentration have been associated with dementia, MCI and Alzheimer disease. Next slide. So a recent 2025 systemic review shows that each 10 microgram per meter square increase in particulate matter 2.5 exposes cognitive decline equivalent to 2 additional years of aging. So there is the emerging recommendation emphasizes urban air quality improvement policies targeting the PM 2.5 and NO2 reduction, protective behavior modification like physical activity, use of indoor air filtration, and prioritizing older adults with cardiometabolic comorbidities for intervention due to high vulnerability. Next slide. One more preventive strategy comes sleep and stress modulation. So in studies, it was shown that sleep disturbances, it is the independent and modifiable risk of cognitive decline. Both short and long duration sleep are harmful. Along with this, psychological stress was also associated to show increased cognitive decline. And combined effect lead to the reduced neuroplasticity and impaired lymphatic clearance. Treating sleep disturbance pharmacological and behaviorally can slow cognitive decline in older adults, particularly those at risk of dementia. Next slide. The next preventive strategy comes the social isolation. Dementia risk was higher in people who were more social isolated, and the social isolation was defined to at least three criteria: living alone, seeing family or friends less than once a month, and participating in no weekly group activities at baseline and less social isolated. So if any two are present in these criteria, these people having the high risk of developing dementia. So the mechanisms linked social isolation and cognitive decline include lack of social stimulation, reduced cognitive reserve and brain resilience. Prolonged stress from social isolation negatively affect cognitive function. So multi-level intervention combining social, cognitive, physical and psychological support may be beneficial. Next slide. After discussing the individual preventive strategy and risk factor in older people, here are some studies that are shown to multi-domain intervention to delay the cognitive decline. This is a finger trial. This was the double-blind RCT done in people included were 60 to 77 years, and the inclusion criteria was cardiovascular risk factor, aging and dementia risk score of at least 6 point and cognition at a mean level or slightly lower than expected for age. The total number of people included was 1200 and the primary outcome was change in cognition as measured through the comprehensive neuropsychological test battery JAD score. Next slide. So if we see the result of this study, the improvement in NTB total score after 24 months was statistically significant in the intervention group compared to the control group. It was also associated statistically significant in processing speed and executive function, while not significant for the memory domain. So here we can see that improvement in executive functioning was 83% higher and processing speed was 150% higher in intervention group than in the control group. Next slide. If we see the odds ratio, NTB total score was have in control group was 1.31 odds ratio, while the memory score 1.23 and executive function 1.29. So the NTB total score fell in 28% participants between assessment at baseline and 24 months. Next slide. So after seeing the result of finger trial, the finger worldwide network was launched. The main aim of this worldwide finger network was generating high quality scientific evidence to support public health and clinical decision making. Next slide. The recently published US pointer RCTs. This US study to protect brain health through lifestyle intervention to reduce risk was done to assess whether finger results generalized to a large, more diverse US population at risk of dementia. Next slide. So this study was the single-blind, multi-center RCT and 2000 participants were included. It was done at the 5 clinical sites and inclusion criteria were people with the increased risk of the cognitive decline. Next slide. So intervention was the physical and cognitive activity, healthy diet, social engagement, and cardiovascular health monitoring. But it was different in the structure group and self-guided group. And the primary outcome was the difference between the intervention group in the annual rate of change in global cognition function assessed by the composite measure of executive function, episodic memory, and processing speed over the 2 years. Next slide. So here we can see the result. The global cognitive composite score increased over time for both groups at a mean rate of 0.24 HD per year for structured and 0.213 HD per year for self-guided after pre-specified covariant adjustment. The main difference in rate of change in these score between groups was 0.029 HD per year. That was the significant difference between the two groups. Next slide. So among the older adult at risk of cognitive decline and dementia, a structured higher intensity intervention had a statistical significant greater benefit on global cognition compared to the unstructured and self-guided intervention. Next slide. So if we see the possible brain mechanism for enhancing maintaining cognitive reserve, we have to focus on the modifiable risk factor that were shown to the 14 modifiable risk factor along with the physical activity, diet, social connection, sleep, and stress management. All these lead to the decreased vascular damage, reduce dementia, and prevent and delay the dementia risk. Next slide. So the take-home message that everyday action can make a difference in brain health, and when combined into the program that target multiple factors like physical activity, improving nutrition, cognition, and social challenge and health monitoring, along with the sleep and stress management, it can have an even more powerful impact. Thank you so much. Thank you so much, the organizing team, for giving the opportunity to present this preventive strategy for cognitive decline in older people. That is the need of power to improve the quality of life in our older people.